Happy Wednesday, everybody. I am Amy Hajari Case. I'm a senior medical advisor at the Pulmonary Fibrosis Foundation, and you are here for our next installment of our disease state education series. I am so excited. Today we are having a COVID-19 and pulmonary fibrosis update. We haven't talked specifically about COVID-19 in quite a long time, and so this is a really great time as we head into the fall season with a new booster available and that back on people's minds to get an update about what's going on, what have we learned in the past 3.5 years, and how do we continue to keep ourselves safe. If you would, next slide. I am joined today by my friend, Dr. Deji Adekinsoye. I'm sorry, I know how to say that better, Adekinsoye. And he is an assistant professor of medicine at the University of Chicago. And he's also the scientific director of the Interstitial Lung Disease Program at the University of Chicago Medical Center, which is one of our Care Center Network sites. He cares for patients with pulmonary fibrosis there. And as a pulmonologist and researcher, his special interest is in prognostic modeling, the genetics of pulmonary fibrosis, and healthcare disparities. And in addition to his work in fibrotic lung disease, he also directs the post-COVID pulmonary clinic and leads the efforts there at improving overall patient outcomes. So I'm very glad to have you with us today. Thank you so much for coming to join us and speak about these really important topics and how they are intertwined. Before I turn this over to you, I am going to just mention a couple of housekeeping items. If those of you who are in our audience today will go to your go-to webinar control panel, which should be to the right side of your screen, mine is, there, look down on the list of items there. You can find where it says handouts. There's a little arrow next to that. If you would like to download a PDF version of slides for today, then you can download them there. Just click that little arrow, it will drop down and there's a link where you can download those for your note-taking or looking back on later. We are recording and we'll upload this to our YouTube channel at a later date. If you are having any technical issues, you can go to the right-hand side there, just under handouts, there's a chat arrow, and if you drop that down, you can drop a chat to our team here and we can try to help you troubleshoot any technical issues you might be having. If you have any questions, we will have time for questions at the end of our session today. Go to the questions tab, drop that little arrow down, and you can type in questions, save them to the end, or type them up as they come to your head, and we'll try to answer as many of them as we can towards the end of our session today. So before I take up too many more of your precious minutes, Deji, I just welcome you again and thank you for being here.
Thanks so much, Dr. Case, for your very kind introduction. And thank you to the PFF and organizers for the invitation to speak this afternoon. I'm delighted to present to you some of the more recent updates on COVID-19 and how they relate to pulmonary fibrosis, a disease that impacts the lives of very many families here in the US and around the world. The first part of my talk will be focused on the interconnections between COVID-19 as we know it today, as well as whatever relationships it has with pulmonary fibrosis, while the latter half will focus on what's new in our approach to therapy for both disease conditions. This is a medical disclaimer that we have to put up here and go by. Any information contained in this presentation is for informational and/or educational purposes only, not intended to be a substitute for professional medical advice. And always consult your personal physician or healthcare provider with any questions you may have regarding your specific medical condition. These are my disclosures, none of which are particularly relevant to the talk today. So I'll begin with a quick background to help us remind ourselves that the pathogen responsible for COVID-19 is really a coronavirus, and it belongs to a family of viruses that historically have been largely considered inconsequential, right? We think about the common cold as a classic example of that. But while they've been with us for literally centuries now, they've caused 3 major outbreaks, epidemics, in the last couple of decades, with the most recent outbreak being the COVID-19 virus that occurred in December 2019. And that was mostly the worst case, obviously. Regarding the anatomical structure of this virus, the surface glycoprotein can actually be found in most body fluids, even though it's primarily a respiratory virus. Unfortunately, viral transmission is largely limited to the respiratory tree, respiratory route, essentially. As of today, we currently have about 700 million documented cases of COVID-19 and about 7 million deaths worldwide. The epidemiologic pattern of the disease here in the US, at least, seems to be in parallel with what we observe worldwide. And that's the global population. While the pandemic began almost 4 years ago, the number of cases that we're seeing actually now has actually more than doubled over the past 2 years. That suggests that there's been an exponential growth in not just infectivity, in cases, particularly in the post-vaccine era. And this has impacted not just the COVID-19 cases, but also COVID-related death. Fortunately, this seems to have plateaued, as you can see on your screen, over the last few months. Now, daily new cases in the US are near the lowest they've ever been since the pandemic began. Fortunately, at this point, our current knowledge suggests that the vast majority of people seem to recover to baseline health status, and very few people have new infections. Although the US appears to be the hardest hit nation across the world, there's still a bit of heterogeneity across the nation. What we see when we start to dive deeper into the data, particularly at county level rates, we observe that hospitalization rates seem to have declined. The vast majority of US states and counties currently have less than 10 COVID-related hospitalizations for every 100,000 individuals in the population. There are obviously a few exceptions to this. You can see in Southern Illinois, some counties in Kentucky, in Colorado, South Dakota, and Kansas. They have slightly more than 20 COVID-related hospitalizations per 100,000 individuals. Similarly, on the right-hand side of your screen, death rates have also plateaued and are much lower than they were at the beginning of the pandemic. And they've particularly dropped in the last 3 months. Most states now report less than 5 COVID-related deaths per 100,000 individuals in the population, except again for Kentucky, Tennessee, Texas, and Vermont at the upper northeast of the map, where the numbers are slightly higher. Now, how does the SARS-CoV-2 virus cause COVID-19? Well, at the asymptomatic stage, what we see is that nasal epithelial cells, which express ACE2, are infected with the virus. We see that here on the left-hand side of your screen. And as the airflow continues through the respiratory respiratory cycle, viral particles infect ACE2-expressing type 2 alveolar epithelial cells within the lungs. And that typically results in symptoms. The most common manifestation of this pulmonary-wise is pneumonitis. Now, typically what you see is you have influx of inflammatory cells at about 7 to 10 days after infection, and then you have disruption of the epithelial endothelial barrier, and complement activation now ensues with deposition of matrix and other inflammatory cells at that interspace. Now, this late stage of severe disease typically occurs with hospitalization in patients and mostly occurs within the ICU when patients get to that stage. Interestingly, similar mechanisms have been postulated to lead to inflammation and fibrosis within the lungs as well in the context of pulmonary fibrosis. What's on the right-hand side of your screen is a cartoon of our current conceptualization of how pulmonary fibrosis ensues within the lungs. And it really involves a suggested pathway where viral triggers can result in epithelial cell injury as well. And so what you have next is type 2 alveolar cell senescence. Eventually, they undergo apoptosis. You have influx of inflammatory cells, again, which include polymorphonuclear macrophages like neutrophils, as well as fibroblasts, which culminates in the eventual fibrotic process that leads to that thickening of that interspace and hypoxia and gas exchange impairment that follows with that. So then, are there shared pathobiologic mechanisms that underlie both diseases? Are there pathways that seem to overlap between both disease conditions? Well, when we comparatively evaluate key characteristics of COVID-19 and IPF, certain key aspects in the disease course become really self-evident. Mortality from COVID in the US now stands at about somewhere between the range of 2 to 5 per 100,000 individuals, like I showed you on the earlier slide. And that's somewhat similar to what you have in IPF, with 4 to 10 individuals per 100,000 patients with IPF dying from the disease. And then you also have risk factors for worsening as well, being very similar across board. Male sex, increasing age, cardiovascular comorbidities, very similar across both disease conditions. Typically, we know that in patients with COVID-19, mortality seems to be driven, at least in part, by hyperinflammation. And critically ill patients who have been hospitalized with severe COVID are often treated with immunosuppressive therapies like dexamethasone, which has been shown to improve outcomes. Similarly, several forms of fibrotic lung disease like hypersensitivity pneumonitis, patients who have connective tissue disease, related subtypes, they're often given steroids, particularly in the context of hospitalization in the ICU with acute exacerbations. Now, both groups of patients with COVID-19 and those with acute exacerbations, they can develop severe radiographic abnormalities that have a very close correlation with survival, and they typically have high rates of mortality as well as greater incidence of fibrotic features on the CT scan. There's recent work also by Richard Allen's group out of Leicester in the UK that has documented the largest IPF and COVID-19 GWAS, that's the genome-wide association study to date. They showed that there's a positive genome-wide genetic correlation between IPF and COVID-19, that's severe COVID-19 risk specifically. Now, their study also demonstrates variants within 4 genes that have been associated with both IPF and COVID-19. You see this on the table on your screen as well. Now, 3 of these genetic variants had differential expression within the blood, while the 4th one, the MUC5B variant you see here, has increased lung expression. But this 4th variant was linked to a 5-fold higher risk for IPF, like we expect. In contrast, it seemed to have an opposite effect on severe COVID-19 risk and was protective for COVID-19. Now, it's important to know that this gene is responsible for producing the mucin 5B glycoprotein, which is an important factor in innate immunity, airway clearance, and protection against bacterial infections, typically in the lungs. There's another more recent multi-ancestral analysis that analyzed over 11,000 IPF cases and over 1.4 million control subjects. And they found that several genetic loci were shared across individuals who were susceptible to IPF and those who had severe COVID infection. So they looked at 25 newly identified IPF loci, and 7 of these had nominal significance for severe COVID infection with a modest but still significant genetic correlation of 0.35. Now, this is in contrast to most other GWAS studies where a significant proportion of the subjects are of European ancestry. In this population, a large proportion or significant proportion were minorities of either African American descent or Hispanic ethnicity. Similarly, again, what we notice here is that the effect of the MUC5B gene variant is reversed. And this is important because this is a really strongly linked risk allele to IPF, and it's protective here for severe COVID-19. Now, when you look at the data on COVID-19, the impact on patients with pulmonary fibrosis appears quite profound. And it's over the last 3 years, there's compelling statistics and results from multiple studies that shows that COVID-19 confers higher risk to patients who contract the SARS-CoV-2 infection. There are worse outcomes, there's greater mortality, increased propensity for lung transplantation for individuals who also have pulmonary fibrosis. On the left-hand side of your screen here is a Kaplan-Meier plot that shows amongst patients who had COVID-19, they compared 251 individuals with IPF to over 300,000 patients without IPF, control subjects. Now, they showed that there was a higher incidence of death or mechanical ventilation amongst the subset who had IPF in this cohort. And this is a 7-fold increase in the risk for the composite outcome that we're looking at here. Even after propensity score matching, where they matched patients based on demographic features, based on comorbidity profile, the risk in IPF subjects still was higher than the control population. Now, there were similar findings also demonstrated in a British study where the presence of ILD amongst patients with COVID-19 again conferred worse outcomes, even with greater mortality rates when the ILD subtype was fibrotic compared to the non-fibrotic ILD subtype. There's another French study as well that looked at similar patterns where they found in univariate analysis that the presence of lung fibrosis doubled the risk of death in patients who had both ILD and pulmonary fibrosis in the context of COVID-19. And after multivariable adjustments, those who required supplemental oxygen had the highest mortality risk. There was a four-fold increase in the risk of death for these subjects. So again, across board, it looks like having both conditions, pulmonary fibrosis and COVID-19, is a recipe for really detrimental outcomes. So what are the common presenting features of COVID-19? Well, we know that these haven't really changed over the course of the pandemic. It still happens to be fever, cough, dyspnea, diarrhea, weakness, and fatigue. Earlier on, as high as 10% mortality rate was observed, but this has really been recognized to be more dependent on the geographical location, on the comorbidity profile of patients, and on the affected age group for the patients in question. Now, I'm showing you here on the screen also a large New York study, this was a few years ago, that suggested that patients who were hospitalized with COVID, they tend to be more on the older side, they tend to be more likely to be male. They tend to have high blood pressure, diabetes, obesity, and at the time of triage, they often would have fever, tachypnea, and hypoxemia. These are the highest risk patients with COVID-19. It's still mostly the case even up till now, although a lot more of these patients are immunocompromised with either post-transplant states or they have comorbidities like CKD that require hemodialysis. And perhaps one of the biggest lessons we've learned so far is that early and judicious use of personal protective equipment helps to prevent respiratory droplets and short-distance aerosol transmission. We've seen that in schools, in the hospitals, we've seen that in public indoor gatherings. Even the US government just a few years back distributed to the general population about 500 million face masks. There was a bid to curb transmission of the virus, and so it became imperative to do that for the general population. And so practically what we do is to prevent, at least mitigate the spread of cases based on established age-old protocols that have worked for us over the years. There's a high premium placed on strategies to reduce infection risk amongst patients who are at risk, amongst caregivers, amongst healthcare providers, and we rely on evidence-based guidelines. So things like face masks, medical face masks for patients doing assessment, for patient transport or transfer, instituting appropriate distancing between patients, use of respirators and eye protection for healthcare providers. All of these things have been shown to be helpful in mitigating the spread of COVID-19. Sometimes they also use private rooms that are pressurized with negative pressure rooms, and occasionally use of non-invasive ventilation where appropriate for these cases. In more practical terms in 2023, when should we start to isolate from other people? Well, the CDC again has clear-cut guidelines that spell out when we need to be under isolation from other individuals. Those who have a positive COVID-19 test or they have a suspected COVID-19 disease, regardless of their vaccination status, should isolate. They should. We want to mask up around other individuals. We want to avoid going out as much as possible. Within the home environment, we want to avoid sharing personal items or bathrooms with other individuals who are not infected. And we want to monitor our symptoms very closely. Obviously, the presence of worsening shortness of breath, dyspnea, or other symptoms should prompt immediate transfer to the emergency department for further evaluation. That typically is a standard approach. But for those of us without symptoms, how should we think about isolation? Well, typically the guidelines state we should end isolation after the 5th day, after day number 5. And if we have symptoms, then we really want to wait until day number 5. And then if our symptoms are better and there are no new episodes of fever, we have absence of fever for at least 24 hours without using Tylenol or other fever reducing drugs, then we can think about ending isolation. The recommendation actually is to stay away from immunocompromised individuals, for high-risk individuals, and to keep the mask on until day number 11. That's after 10 days. Or if you have 2 sequential negative tests, 48 hours apart, then you can take the mask off as well. Those are the current guidelines as of today from the CDC. Now, just we spent most of the past 20 minutes talking about acute COVID, and rightfully so, because I really do think without any doubts that COVID-19 is the most consequential exposure of our generation, without doubt. But there have also been concerns about what are the long-term consequences of this infection? What are the sequelae downstream? What I'm showing you on the screen here is a New York Times headline from a couple of years ago that called attention to long COVID symptoms. And there have been several articles, several reports in the literature after that. It says, what if you never got better from COVID-19? Well, we know that pulmonary fibrosis can develop either following chronic inflammation, following infection, or even idiopathic cases of pulmonary fibrosis do occur. And we think some of these may be age-related in the fibroproliferative process. What I'm showing you on the screen here on the right-hand side is a chest CT of a 66-year-old male patient of ours who was found to be COVID-19 positive. His chest CT 6 weeks later, as you can see, shows rapidly progressive fibrosis. Now, it's unclear if COVID-19 was a trigger, was the cause, or if it exacerbated what we are seeing on the screen. Be that as it may, we now know that those individuals who contract SARS-CoV-2 infection can develop symptoms that extend well beyond the acute phase of COVID. They can last for weeks, for months, and even some for years after the initial infection. The WHO calls this constellation of symptoms post-acute sequelae of COVID-19. Now, they typically involve physical symptoms, cognitive findings, and sometimes mental health impairments as well. They're collectively called PASC, sometimes called long COVID, sometimes called post-COVID-19 condition. What I show you on the screen here is what I think is very notable amongst these, and that's the presence of dyspnea, shortness of breath, and pulmonary fibrosis. Again, pulmonary fibrosis as a key component of PASC. In fact, there's a recent large study from the NIH-supported RECOVER Consortium on the right-hand side of your screen here, published in JAMA just a few months ago now. And they looked at data in over 9,000 subjects with and without SARS-CoV-2 infection across 33 states here in the US. And they used the data acquired to develop a definition for PASC based on symptoms. What they found was that over 30% of PASC positive subjects complain of chronic cough. Now, mind you, these are patients months after COVID infection. So they had chronic cough, again, which is a symptom that's very common in the context of pulmonary fibrosis. Now, what I'm showing you here are other chest CTs from a few of our other patients here at University of Chicago who had COVID. The top three panels are for the same patient who was a gentleman in his 50s. He got infected with COVID in April 2020, and 4 months later developed extensive fibrotic changes in the same regions where he had COVID-related CT abnormalities. The bottom three panels are three different patients, several months out from acute COVID. All of them had extensive fibrosis on their chest CT scan. Now, obviously, this is very concerning, obviously. At present, the long-term PASC symptoms, features of COVID-19 are mostly speculative because we don't have a ton of data, and we shouldn't assume about progression without appropriately studying these patients prospectively. We don't have a lot of data to do that at this point in time. Now, these are other axial CT scans from the same index patient I showed you earlier, with a clear view of progression of fibrosis during the period of the pandemic after he got SARS-CoV-2 infection. As you can see, subsequently, the fibrosis again seemed to be worse. And again, I'm showing you the same thing here again, which recapitulates what we initially saw in the last few slides, where now you see not just in the mid to the lower lung zones, in the upper lung zones, features of fibrosis as well, which seem to progress. Beyond the ground glass opacities that I talked about that could occur, patients often present with focal areas of consolidation. You can see on the bottom left-hand side of the screen, focal areas both lung zones, on the left and the right lungs, and the peripheral regions, features of what we call ground glass opacities, sometimes more nodular, sometimes more consolidated. Now, this isn't surprising because we know that viral illnesses commonly cause organizing pneumonia. That's what you're seeing on the screen. They sometimes cause hypoxia as well, with attendant lung function impairments. And these can impact quality of life of patients as well. In the pre-COVID era, these patients will often get a prednisone burst, and they get a long and slow taper in the setting of cryptogenic organizing pneumonia. That's to prevent recurrence. As you can see from the CT I'm showing you on the screen, we've adopted largely this approach for patients with COVID-19 with really good results, and they typically would have complete resolution of their parenchymal abnormalities. In the particular case I'm showing on the screen, we elected to use a more rapid taper over 6 weeks because here the cause is known, it's not really unknown. And a lot of this data you see was extrapolated from reviews and case reports and case series on organized pneumonia. I'm showing you here a very nice review in the New England Journal of Medicine, published by Talmadge King from last year, that sort of helps to guide our approach to managing organized pneumonia. Now, I'll tell you here that while this was extrapolated from our limited knowledge of treating organized pneumonia from decades of managing these patients, a word of caution is important. We don't have any well-controlled studies that validate the use of prednisone bursts in the context of COVID-specific OP, organized pneumonia. As we expect in pulmonary fibrosis from any cause, it can impact lung function. This is a gentleman who is 75 years old who had hypertension, diabetes, CKD, and other comorbidities, who was diagnosed with COVID-19 in early April of 2020. He was admitted a couple of times, and he got a screening CT scan, coronary CT, a few weeks before he got COVID. He had a protracted hospital stay. Subsequently, in May of 2020, had a repeat CT scan, which, as you can see on the screen, depicts frank fibrotic lung disease. You see evidence of traction bronchiectasis, some honeycombing, some reticulation, some ground glass opicities. At the time of discharge, he did require supplemental oxygen. He started rehab, cardiopulmonary rehab, and he had for 3 weeks, and then he went home. Subsequently, was initiated on home physical therapy. On the right-hand side of the screen is his PFT pattern. You see a restrictive flow pattern on his PFT, the forced vital capacity specifically. And with pulmonary rehab that continued, these FVC improved over time, over the space of several months going forward. This should be 2021 or 2020. And we see here that this aligns with the thought process that the vast majority of patients with post-COVID fibrosis do not tend to progress. Most of them either remain static in terms of lung function impairment and fibrotic features, or in certain cases may even improve in their lung function with appropriate institutional therapy. Now, these are 3 other patients with post-COVID lung function tests performed. One notable feature we've been observing is the classic pattern of a disproportionate reduction in the mid-flows. Now, this is the forced expiratory flow at 25 to 75% of the pulmonary volume. We call that the FEF 25 to 75%. Now, the first patient here, patient number 1, is a 60-year-old female with a prior history of lymphoma who completed chemotherapy months before getting COVID. And her prior PFTs were normal at the time of chemotherapy. Mid-flows were in the high 90s. She got vaccinated around the time of her last chemotherapy. She got COVID in June of 2020, and a few months after, her mid-flows had dropped to 75%. Now, cases 2 and 3 are somewhat similar. Again, 34-year-old female and a 42-year-old male, both with previously normal PFTs, but now having small airway flow impairment. Now, some of these may respond to bronchodilator therapy with albuterol. It sometimes can also provide symptomatic relief, although I would say that's not universal, and so I think it has to be individualized per patient. Now, there are other biological features that may predict the occurrence of post-COVID fibrosis in those who have infection with SARS-CoV-2. What I'm showing on the screen here is very elegant data from Christine Garcia's group out of Colombia, published by Dr. Claire Magroda, where they showed that there is a very high prevalence of fibrotic-like patterns on the CT scans of patients who had recovered from COVID-19. This is 4 months afterwards, after the acute infection. Many of them had really prominent features of fibrosis. I'm talking traction bronchiectasis, they had reticulation, they had fibrotic features that appear to be much more prominent with greater severity of COVID-19 disease. The greater the severity of disease, the longer the duration of mechanical ventilation, the more prominent these fibrotic features appear to be. What was most impressive to me actually was the fact that there was a very strong negative correlation with peripheral blood leukocyte telomere length, even after adjusting for age. We often think about telomeres, those caps on the end of our chromosomes that protect the DNA from degradation, kind of like the caps on the end of your shoelaces that protect the shoelaces from fraying. Those telomeres typically have been referred to as a biomarker for aging, for stress, for other environmental or genetic features. Now, in these individuals, even after adjusting for age, there was a very strong correlation with telomere length in patients who had COVID-19. Now, this suggests that it supports that idea and suggests that short peripheral blood telomere length, leukocyte telomere length specifically, may be a risk factor for developing fibrotic lung disease. Different subtypes of pulmonary fibrosis have also shown that in the literature outside of COVID-19 in of itself. Now, we also looked at this. We took a closer look at the occurrence of COVID-19 post-COVID features here in the US. So specifically evaluating post-COVID fibrosis in a large study, a large database, the N3C cohort, that's the National COVID-19 Cohort Collaborative. And we found that in over 450,000 hospitalized adults who had COVID-19, the incidence of pulmonary fibrosis was relatively high, about 1.1 per 100 person years. Now that's a concerning figure because again, it indicates that there's a real risk, a high risk post-recovery. That's over and above the general risk in those without COVID-19 of 0.6 per 100 person years. Now the study particularly highlighted that certain pre-COVID-19 drugs, so specifically rituximab and cancer chemotherapy, appear to be significantly associated with a higher risk, a higher incidence of post-COVID-19 pulmonary fibrosis. Now, this in my mind begins to emphasize the need for heightened surveillance, heightened medical vigilance for those patients who are getting these treatments in the context of getting of risk for COVID-19 subsequently. Now, we found that while drugs like amiodarone, which previously have been linked to COVID-19, in this case showed no accentuated risk, there was no significant correlation, the use of recent rituximab, cancer chemotherapy, increased that risk for post-COVID pulmonary fibrosis. So there may be a complex interaction between drug treatment and post-COVID-19 health outcomes, specifically pulmonary fibrosis. So given all this data that I've showed you, given these findings, are there preventive strategies we should be thinking about implementing? Are there therapies that we can bring to bear on our patients to help curb the effect of COVID-19 and the downstream effect months after getting COVID? The landscape has changed dramatically since vaccines became available in April 15 of 2021. It's really simple. According to current CDC recommendations, the most effective, the most important strategies to prevention are focused on encouraging vaccination for our patients with COVID-19, for COVID-19. For our patients with pulmonary fibrosis, we want to implement strategies that have been known to prevent infection or to reduce spread of infection. Again, vaccination and wearing masks in the setting of exposure becomes really important in curbing that risk and mitigating spread. As of today, from the CDC, for those who are not moderately or severely immunocompromised, if they are unvaccinated, they should get at least 1 dose of the Moderna or Pfizer vaccine, or at least 2 doses of the Novavax vaccine. If they're previously vaccinated, it doesn't matter how many doses, then just 1 dose of any of these will suffice. Again, this is for those who are not moderately or severely immunocompromised. Well, how about those who are moderately or severely immunocompromised? Well, for these patients, if they are unvaccinated, they should get at least 1 dose of Moderna or Pfizer, or at least 2 doses of Novavax. That's the current recommendation. So she had at least 3 doses of Moderna or Pfizer, or at least 2 doses of the Novavax vaccine. If they were previously vaccinated with 1 dose of the Moderna or Pfizer vaccine, then they should get at least 2 follow-up doses, as you can see on the screen, with the intervals specified depending on the vaccine type you're getting. If they previously, however, had 2 doses of either Moderna or Pfizer, then just 1 dose will suffice as a follow-up dose for either of those 2. On the other hand, if they previously got 3 doses of any mRNA vaccine, then just 1 follow-up dose of any of these 3 different types will suffice as per the current recommendations as of today from the CDC. So what's the evidence for revaccination? Why do we care about vaccinating these patients? Well, we understand now, as we've gotten to study the vaccines better over time, that post-vaccination antibody titers tend to wane over time. They reduce over time. The further out you are from the last dose of the vaccine received, the lower your serum IgG antibody titers get to be. There's also data that this reduction in antibody titers occurs faster over time in those who've been vaccinated compared to those who had prior infection. So why do we care for boosters then? Is there any evidence for this? Well, apparently yes. Boosters have become necessary for sustaining adequate titers of neutralizing antibodies following the initial vaccination. I'm showing you here a very nice study published about 2 years ago that shows the increase at sequential intervals. This is 2 weeks and 4 weeks intervals for patients who received the vaccine, right? And this is for the Johnson & Johnson and Pfizer vaccine. And so the NIH recommends that a full course of vaccination be given to everybody who's eligible. But there was a recent recommendation for the use of pre-exposure prophylaxis for those individuals who were at high risk and can't be vaccinated, that is, can't get full vaccination regimen. Well, the most common medication at that time was Evusheld, which was given as IM intramuscular injections every 6 months. Now, that recommendation is no longer valid. With available data on the current COVID variants, the NIH panel recommends against the use of Evusheld as pre-exposure prophylaxis for COVID-19. Now, similarly, the NIH panel also recommends against using monoclonal antibodies, particularly bamlanivimab, as well as etesevimab, or the combination of caricivimab and imdevimab for pre-exposure prophylaxis, post-exposure prophylaxis for those who had been exposed to COVID-19. Obviously, we quite a while ago have abandoned the use of hydroxychloroquine or chloroquine for this purpose as well. Now, there are certain drugs that may be allowed as post-exposure prophylaxis in the context of a clinical trial. The panel does not recommend against that. So for those who are in a clinical trial, that's allowed. Now, regarding therapies for COVID-19, these largely depend on the hospitalization status of the individual. Are they hospitalized or are they non-hospitalized? And over the next few slides, I'll try to touch on this broadly a bit. For outpatients who are not on oxygen therapy, the treatment modality focuses on Paxlovid and in certain rare instances, getting remdesivir for those who are at high risk of progressing to severe COVID. Now, this data was based on a randomized controlled trial a few years back in which over 1,000 patients who had COVID-19 were randomized to placebo or remdesivir. And after a period of 9 days, a median period of 9 days from symptom onset, patients got these medications. Remdesivir shortened the median time to recovery from 15 to 11 days. That's a 27% reduction in patients who got the treatment arm. Now, patients in the trial, I will say this, who had worsening respiratory failure, was called advanced respiratory insufficiency. Many of them were intubated. They didn't respond favorably to remdesivir, so it didn't really work in them. And it's thought that the processes underlying that were more related to cytokine storm than the viral replication in of itself. For those who are hospitalized for other reasons and they have an incidental discovery of COVID-19, the treatment regimen for these patients is typically managed like those who are outpatients. So if they have a high risk of disease progression to severe COVID without oxygen requirements, typically we give them remdesivir. If they do require oxygen, then we add dexamethasone to remdesivir for these patients. And as oxygen requirements seem to increase, they may get tocilizumab or baricitinib, depending on the context. Now, this is similar for those who are hospitalized on high flow nasal cannula and who have non-invasive mechanical ventilation or even on ECMO. Those patients do not get remdesivir. Now, hospitalized patients typically will get prophylactic anticoagulation with heparin, except for low dose, those on low dose supplemental oxygen where it doesn't seem to have a lot of value. Now, why the recommendation for anticoagulation with heparin? Just about a year ago, what I'm showing you here is additional data from a nice study published in JAMA that showed that the risk of venous thromboembolic disease and even arterial thrombosis in those who have COVID-19 seem to be higher in hospitalized patients, and it seems to be related to the risk of, or very similar to the risk of patients with influenza. But when you compare the two, COVID-19 patients to influenza patients, those who have COVID-19 have a much higher risk of getting deep vein thrombosis, DVTs, or VTEs in the lungs, or even arterial thrombosis, in contrast to those who have influenza and are hospitalized for that reason. Now, it appears also that those who have COVID-19 seem to have increased risk with increasing age unlike what you see with influenza, where the age doesn't seem to be dramatically increased with rising age. Now, when we think about all of this summatively, what should be our approach to treating these patients, right? We have talked extensively about COVID, but remember, they also have fibrotic lung disease underlying as an underlying factor in the background before they got COVID. Now, when I think about this, I'm drawn really to this nice algorithmic figure in the New England Journal that begins to highlight what should be, in my mind at least, an iterative approach to how we care for these patients. In addition to thoughtfully addressing their underlying SARS-CoV-2 infection, treating for PASC or long COVID, giving pulmonary rehab, and whatever other treatments you want to give, we need to carefully balance all of that with the need for either immunomodulatory therapy based on diagnosis of the pulmonary fibrosis subtype, or the need for antifibrotic therapy if they have fibrotic lung disease. Now, these patients should be carefully monitored with pulmonary function tests to determine if their disease is stable. For those who have disease progression, you want to have an iterative process again to assess for what you might be missing, and then the need for additional therapies before going back to see if it has ameliorated their disease, or you now have stable disease in their monitoring parameters. So again, it's an iterative process that helps us think about, should we be reconsidering alternative therapies? Should we stick to what we currently are doing regarding immunomodulatory antifibrotic therapy? Or do they need adjunct care, supplemental oxygen, referral for pulmonary, for lung transplantation, or other additional interventional strategies? So in conclusion, we have seen that COVID-19 significantly worsens the health risks and complications for patients with pulmonary fibrosis. There is ongoing research that suggests that there's a bidirectional relationship between COVID-19 and pulmonary fibrosis. It appears that the virus may potentially trigger fibrosis in some patients, but again, there's abundant data that pre-existing fibrosis may worsen outcomes in COVID-19. There are comprehensive preventive strategies we should be implementing. These include vaccination, adhering to health guidelines, regular health monitoring. All of these are critical for managing patients with pulmonary fibrosis in the context of COVID-19 to help mitigate the risk and manage the dreaded disease progression that can occur in the context of pulmonary fibrosis. So there are a lot of people to thank, especially members of our Chicago ILD team, research funders, amongst which the Pulmonary Fibrosis Foundation carries prime precedence. And our utmost thanks actually goes to patients with pulmonary fibrosis, their caregivers, their family members, and really because of them, we are stronger together in our fight against this deadly disease. So I'll stop here and take questions from the group. Thank you very much.
Great. Thank you so much for that. I took so many notes for my own self. I think hopefully I retained some of that, and I learned a lot today as well. Before I launch into our questions, I am going to just remind everyone in our audience, if they want to download a PDF version of the slides, go to the control panel on the side of your GoToWebinar screen and just look down there to where it says handouts, hit the little triangular arrow there, and you can click on a link and it will download to your computer so you can see those in PDF form and print them out, and save them to your computer and print them out on your own leisure later. But those will save. Please, if you would like to do that before we end our session today. And then also, if you have questions, we're getting some great questions here. If you have others that you would like to submit for us to talk about, I would love to hear those, and we'll try to address as many as we can. So if you're ready, I'm just going to launch right into some of the questions that we have. Is that okay with you?
Absolutely, yes, please.
All right, so I'm going to start with my question because that's my prerogative since I'm getting to be the host today. On slide 13. You had a timeline. It was actually really great. I can't remember. I've seen this, but it's been a long time, about symptom onset and progression and stuff like that. And so 2 questions. One, has the fact that my understanding is something like 98% of the population at this point has been exposed to SARS-CoV-2, either in the form of infection or vaccination or both for many people, has that changed this timeline at all? Particularly in that there used to be, quite a lot of people with asymptomatic or pre-symptomatic COVID that we would worry about spreading. And has that changed? And I'm alluding to some data I saw recently, the timing of the viral load and how it peaks and how our tests might come out. So if we test early and have, fever and aches and we test and it's negative, what should we do with that information?
Yeah, that's a great question. The timeline of itself for incubation has not really changed dramatically. What has changed is the presence of symptoms after infection, and I think that is largely due to herd immunity, to vaccination, to much more conscious adoption of strategies to mitigate the spread of infection, so mask wearing and PPEs. What I show you at the bottom here is an excerpt from a very nice publication in Lancet that looked at non-survivors for COVID-19. There's actually a very similar timeline for those who are survivors for COVID-19. The main difference between the two is the requirement for mechanical ventilation, typically invasive mechanical ventilation for the non-survivors. But you could pretty much overlay this timeline as well on those who are survivors for COVID-19. We don't have a lot of patients now who are symptomatic, and so the fever, the presence of cough is not quite as present or as evident and doesn't last quite as long for those who get infected. We still have some shortness of breath or a sensation of dyspnea, and typically that still occurs at about days 5 to 7 for the vast majority of patients post-exposure or post-infection. Now, again, these are average values. Again, it's a bell curve for the general population. It may be a few days earlier, a few days later, depends on the individual and context. But the timeline, by and large, has still really been the same, except for the fact that we don't have as overt presentation with symptoms, and we don't have as many patients progressing to severe COVID requiring mechanical ventilation anymore.
That's a great explanation. So in the case of somebody who doesn't progress to that illness, their timeline would cut off a bit earlier in this scenario. They would recover at day 5, 6, so on and so forth, rather than progress on.
That also informs why when patients get symptoms, you can see here that most patients will have maybe around 7 to 8 days about of symptoms. But when patients who now have a shorter duration of symptoms due to vaccination, due to other herd immunity and other factors, the recommendations are at day 5. If you don't have symptoms, it's okay to stop. And if you do have symptoms, mask up till day 10 so that you do not spread the virus to people who may be immunocompromised or at risk of getting the virus. So at least day 10 should be inclusive. And after day 10, you can take off the mask, or after having 2 negative SARS-CoV-2 tests that are 48 hours apart.
That's great. This is actually a really good question. So a couple of questions about vaccines. I'm going to kind of back them up to each other. I'll give you one and then I'll give you another one instead of stacking questions too much. One question about sort of the new COVID 2023 COVID vaccine. I know you very nicely explained that our immunity changes over time. That graphic is really helpful. Can you also comment on the fact that it is kind of reformulated, right? It's a different vaccine than what we have previously, if we've previously been vaccinated, this is not something we have seen before. It's a little bit different.
Yeah, so these are the mRNA vaccines, which are not historically what we typically have been exposed to in terms of other viruses, RNA viruses. We think about the measles, chickenpox vaccines that we get. These are a different brand of vaccines. What really differs for this is the carrier medium, the agents through which the epitope is carried. And so that's why you cannot really expect very similar responses in terms of the serum IgG titers to mixing and matching the different vaccine subtypes across board. But be that as it may, the Moderna and the Pfizer vaccines have very, very similar design of formulations. And so when patients get one, they can often get the other with a boost in their serum IgG titers. That's the antibody titers. Not so much for Novavax or the Johnson & Johnson vaccines. Now, the mRNA vaccines, by and large, are interchangeable, and that's why the recommendations tend to stick to the same for them. Very, very minimal differences in terms of the medium through which the epitope, the active component of the vaccine is carried. That's the mRNA specifically is carried, but they're very, very similar across board.
Can you talk a little bit about sort of why the 2023 vaccine recommendation is different from the original that was offered a couple years ago? I think my understanding is like the virus itself has sort of changed and had, it's the original is sort of a great grandfather there, and now we're dealing with descendants of that, and maybe those things look a little bit different.
Yeah, so there was a slide I took out because again, it's no longer as relevant as it used to be. This talked about the different, and I just put a big X right here. You might see in the background, there are different strains. We actually walked through multiple strains of the virus, from alpha to beta to delta to multiple variants of Omicron. And as the virus evolved, it became imperative that we caught up. Right? We're trying to play catch up to make sure that the vaccines are effective against the most recent variants of the virus. And so that's why the newer formulations, the newer designs of the vaccines typically targeted at the prevailing variant, the prevailing strain of the vaccine in the population. And so the earlier designs were not going to be as effective as newer virus strains because, again, they hadn't manifested at that point in time. And using them, it's going to be dated at this point in time. So the newer vaccines are actually much more effective at targeting current prevailing strains in the general population to mitigate, not just disease severity if you get it, but also spread of the virus across the population.
That's fantastic. Very glad that we have an updated version for the season. Okay. Oh man, these are so good. Let's go to somebody with ILD or pulmonary fibrosis that has had a COVID infection recently, is potentially scheduled to come up and see their pulmonologist relatively soon. They feel better. Should they get their, maybe they're having PFTs and walking and so on ahead of their visit? Should they go through with that? How long would you expect to kind of see the dust settle and things like that before you'd want to see those tests again without being skewed because of the recent infection?
Yeah, so we typically want to make sure that we are managing the patients per guideline therapy. Patients need to get tests performed. They need to get their studies done. They need to be able to assess their baseline disease status and intervene as needed in whatever circumstance it is, but not at the risk of contracting a virus themselves or spreading virus to other susceptible patients. We want to be very mindful of that. And so while each individual case is different, the recommendations are for those who had recent infection, they should stay at home, absolutely, because the risk of getting both, like we showed, pulmonary fibrosis and COVID, is dramatically high. And so we want to prevent that spread to other individuals. Now, if it's outside of that initial 5-day period when they got infected, then they can actually put on a mask and come to the hospital. There is a concern about PFTs, pulmonary function test performance, potentially spreading the virus. And that's why we advocate currently for healthcare providers around patients with recent infections to also wear masks, particularly when someone has recently been infected with COVID. And so there is a real risk of spread of the virus, but putting on masks and adhering to these guidelines should at least mitigate that risk substantially for the index patient, but also for other potentially high-risk patients in the hospital around that time.
That's a great answer. Thank you. Yeah, I tend to think, as far as that individual patient goes, outside of the risk to others, which of course we want to make sure we're following the guidelines for, but some of that depends on sort of how sick they were and how close they are feeling to their usual baseline. but I would recommend keeping that follow-up appointment if if you're sort of outside that isolation period, just to check in and make sure, we're keeping monitoring on folks that, and their status and how their respiratory status is doing. Okay.
Yeah, that's a really good point. I would also add that with COVID, we've learned a lot now. We now rely increasingly on telemedicine. And so healthcare providers can actually check your pulse oxygen saturation at home. You can check your peak flows at home. In fact, some patients have home spirometers, which can be performed at home. And so if we are able to leverage telemedicine to the maximum for such patients who still need to get follow-up visits and get assessed, we can do that on virtual platforms that can help still at least plug in that gap before they physically are able to come to the hospital for the next visit. And we've been seeing this increasingly being leveraged across the world, not just here in the US, in the context of COVID-19.
Yeah, that really has accelerated my use of telemedicine for sure. So I'm going to switch a little bit and have a few questions about pulmonary fibrosis related solely to the COVID infection, not pre-existing. And I did hear you mention, and there's a question about this, with severe COVID infections, with hospitalization, I think I heard and I wrote down that the majority of patients with post-COVID fibrosis do not seem to progress. Some may seem to improve to a point, but maybe kind of go over that a little bit for us one more time there.
Yeah, that's a good point. So this has been looked at in large case series. We've noticed that many patients who get COVID-19 down the line seem to have a CAT scan if their disease is severe enough for them to be in the hospital. And with the CAT scan, they see frank features of fibrosis. Now, it's not clear what causes the fibrosis. Is it COVID that caused it? Is it COVID that accentuates it? Is it an incidental finding in patients who would have developed pulmonary fibrosis anyways? We don't know, but we know for sure that these patients have pulmonary fibrosis. And we also know they got COVID. So we're not sure exactly what caused it. Now, that fibrosis in the lungs, the big question about it is, does it progress, right? When we think about pulmonary fibrosis, we worry about disease progression in terms of lung function decline, in terms of advancing symptomatic burden, in terms of spread of the disease to previously uninvolved parts of the lungs. So we worry dramatically about progressive pulmonary fibrosis, whether IPF or other variants. The same thing with post-COVID pulmonary fibrosis. What we have noticed, though, is that when these patients get lung function tests after they get fibrosis, the vast majority of them, though they may have lung function impairment, do not seem to have worsening of their lung function over time for those who survive. And that has been quite reassuring because, again, it will be devastating to have every case of post-COVID fibrosis declining over time. We don't want that. There are those who progress. It's the minority of patients, and those are the ones we worry about the most. Factors that have been linked to progression are the typical factors that we see in other progressive forms of pulmonary fibrosis like IPF: male sex, smoking history, shorter telomeres, concurrent comorbidities like CAD, coronary artery disease, and other conditions. And these are the ones we worry about the most. When we look at the lung function for these patients, a lot of them seem to have a relatively stable FVC, the forced vital capacity, stably low, stably impaired. And with instituting pulmonary rehab, lung function testing seems to improve over time, over the course of the recovery period. So that in of itself is reassuring. Now, it's too early to say. I think this should be very carefully studied in the context of a prospective, large, multi-center evaluation for us to make any firm conclusions about the course of post-COVID pulmonary fibrosis.
Absolutely. Those are great comments. And we are right at the hour, but I have to ask this last question because I think a lot of people have it. Can you just talk briefly about the use or potential use of antifibrotics in post-COVID pulmonary fibrosis? And I think we would be talking there, and you can clarify if I'm wrong, but about people who are having progressive disease and not those who are, as you were describing, either staying stable or improving.
Yeah, that's a very practical question. I think it's important to remember that patients who were initiated on anti-fibrotic therapy were initiated originally because of concern for disease progression. These are patients who had a pulmonary fibrosis subtype, like IPF, that is found to be almost uniformly progressive, or they met criteria for the newly defined progressive pulmonary fibrosis subtype, the PPF syndrome, where patients have lung function decline, they have increasing radiographic abnormalities, or worsening symptomatic burden. These patients should continue to use their antifibrotic medications because the ultimate goal is to reduce the decline in lung fibrosis. We know that that inevitably leads to demise of patients, to requirement for lung transplantation, to increased symptomatic burden, in many individuals to the requirement for supplemental oxygen as well. The goal is to buy time as much as possible by instituting and maintaining the use of these therapies, because the studies have shown that on average, they tend to reduce lung function decline. That is not the therapy for patients with post-COVID fibrosis. We still don't know what the optimal effect of antifibrotic therapy is in the context of post-COVID-19 pulmonary fibrosis. If they progress, then it makes sense based on the INBUILD trial to initiate antifibrotic therapy if they meet criteria for starting the drug. If they don't, then we don't do it. And then lastly, I would say that when we give patients these antifibrotic medications, we are treating to a target, we are treating to a goal. What is the goal? If patients are not declining, then why are you giving antifibrotic medications? So we typically are monitoring the lung function impairment to see that reduction in the decline, to help them maintain lung function without declining. Or if they have a very high risk of lung function decline, then it makes sense to give them the medication to reduce the anticipated lung function decline that these patients almost inevitably demonstrate.
That's a perfect answer. I mean, to be honest, that's really great. Thank you. It's super helpful. Deji, could you, if you do me a big favor and forward your slides towards the end there, I'll give everybody one last chance to download those slides in the handouts tab on your GoToWebinar control panel. I will ask everyone to please give us your feedback. Just stay for a moment after we end the webinar here. Give us some feedback about our session today and things you might want to hear about in the future. And thank you all for being here, for listening, for your great questions, and for your engagement today. And Deji, friend, thank you so much for being here. This is such a great topic for our community, and I learned a ton. And I'm going to be going back to watch this watch the video later so I can pick up on a few more things. But thank you, everybody. We'll see you next time. Have a great rest of your day.
Thanks very much for having me. And thanks, everybody, for logging in.